You know, an African proverb says that if a man does not eat at home, he may never give his wife enough money to cook. Now, that represents exactly the current state of Africa's healthcare and the medical tourism its leaders take pride in. What Ugandans spend yearly on medical tourism can build not one, not 5, 10 hospitals every year in that country. Now, some African leaders have left home to give up the ghost abroad, but the ghost of their failures and inactions still haunt the continent. Welcome to Village Square Africa. I'm Sulaiman. You know, medical tourism is a global industry worth billions of dollars. Now, its current worth is pegged at $20 billion. Now, a large amount of the value of medical tourism comes from one continent, Africa. At least $5 billion has been spent yearly by Africans in the last 5 years. Nigerians are believed to have spent $200 million to Indian hospitals in 2019 and medical tourism, and this is just a part of the big industry. The continent could be losing as much as $1 billion every year to medical tourism, and this greatly affects the development of the healthcare sector on the home front. Notable African leaders like late Zimbabwean President Robert Mugabe, late Gabonese President Omar Bongo, late Ethiopian Prime Minister Meles Zenawi, former Zambian President Lewi Wanawasa, and Pierre Nkurunziza, and most recently former Tanzanian President John Magufuli all died in foreign hospitals while they sought medical attention. Now, Africa's 1.2 billion population is a huge market for its healthcare sector, but its leaders are content flying abroad on taxpayers' money in state-of-the-art hospitals while they leave the health sector at home in ruins. The continent holds 24% of the world's disease burden, but has just 2% of the world's medical doctors. Poor investment in Africa's healthcare has seen many die from preventable diseases. And just when you think that that's enough, African leaders are on the next plane. In search of what? Wellness. That brings us to the conversation today on The Square. I'm excited to have Dr. Osahon Enabulele. He's the President, Commonwealth Medical Association, and of course, Dr. Immanuel Agogo, Global Health and Health System Experts. Gentlemen, good to have both of you here.
Thank you very much, Suleiman. Nice to see you again.
I'm excited as well. Well, I know for two of you, this isn't a nice topic to deal, but again, it's something that requires you both to weigh in so that people can understand the import of what we're dealing with at the moment. Let me start with you, Dr. Enabulele. The impact of medical tourism on local economy. In this case, we're talking about different African countries, but where you're based at the moment, Nigeria, can't be overstated. What is the root cause of this problem when we talk about medical tourism? Medical tourism, like you know,
is generally regarded as travels that are done outside one's country in search of medical care. And usually there is this tinge of tourism associated with it in terms of other activities that take place in the course of procuring healthcare services, which can be of different dimensions in terms of curative, preventive, rehabilitative, and so many other levels of healthcare engagements, but primarily with a tinge of socio-economic involvement. And that is what, of course, leads to the kind of immense loss of revenue that goes out from the countries, the source countries. But back to your question, the reality is that there is what I want to call a concatenation of factors responsible for medical tourism in Africa, especially of the African political leaders. Some will gladly want to talk about the issue of the African leaders will always want to remind you of the issue of poor healthcare facilities, and of course the poor state of healthcare in their countries. And the question is, who is supposed to fix those environments? So that is one reason they commonly give, that the healthcare environment in Africa is not good. is deficient. Some would say, oh, people have lost confidence, as a result of which people would say they've lost confidence in the healthcare system in Africa. Of course, there are other reasons. The issue of diagnostic facilities not being available in some African countries, the issue of expertise and all of that. But I will single out from my own experience and from my own knowledge, especially on account of foreign medical tourism or outward medical tourism by African political leaders, what I will class as colonial overhang. A lot of them believe that until the white man touches their skin or attends to them, they will not get the desired treatment. They believe that all the experts are out there outside their country, and so they have to, of course, get the white man to attend to their care. But unfortunately for them, when they even travel to those countries, it is the same Africans they have there, attending to them. So I see colonial overhang as a major factor. Again, it's the issue of the inordinate quest for extra-code by most political and public office holders who indulge in medical tourism. So everybody wants to have a bit of a share of the government resources. And so they line up all sorts of foreign trips in the name of procuring healthcare services. But again, the whole intent is to harness government extra-codes. And imagine when you have hordes of aides going with government officers. Imagine you multiply that by 4 or 5 times. You can estimate the amount of resources being channeled away from those countries. So there are several other reasons, from the real to the mundane to the absurd. And I've just tried to summarize them to say that, look, in most cases, it is just as a result of the poor commitment to the healthcare environment in Africa, especially by the governing leaders in Africa. For the other ordinary citizens, yes, because they have a poor commitment to the healthcare development that has left most of the healthcare facilities stranded, dilapidated, forgotten. So they increasingly lost confidence. And when they see their leaders go abroad, they also believe that, look, the best way is to also go abroad and attend to their needs. So a host of factors really account for outward medical tourism, but particularly driven by the poor commitment of African leaders to the healthcare, to the development of their healthcare systems.
Dr. Enabulele, I like the perspective you've thrown in. We have 2 categories of persons. First, the African political leaders, failure which has actually resulted into some other wealthy Africans, towing the same, line of action by the African political leaders. Let me bring in Dr. Agogo. Listening to your colleague, Dr. Enabulele, what readily comes to mind is failure of leadership. And, nations, for instance, like South Africa and Tunisia have quite an impressive medical tourist attraction on their own. So, but do you think they are the closest examples that should be understudied by African countries at the moment?
One of the things that we need to be clear about the idea of medical tourism is that the underlying issue around medical tourism is an issue of trust. So there's a study that was done by PwC in 2016 that assessed Nigerians, especially in the context of the fact that we think that anywhere between $1 to $1.5 billion annually is being spent on medical tourism. So there was a study done by PwC asking Nigerians why were they more likely to use, facilities outside the country. And the underlying problem was an issue of trust. So the question was that a lot of Nigerians felt they could not trust Nigerian medical health systems. And the reason why people go outside the country is that they may be inclined to trust health systems in other countries, Tunisia or wherever you're calling. And the studies also show, there's another study that looked at what kind of procedures were people going out for? So orthopedic procedures, cancer treatment, problems around kidney problems. So we have a lot of issues around people going for kidney transplants, and then heart problems. So these are the main bulk of areas. But you see, I need to draw your attention to the fact that if you travel across to many of the other countries where Nigerians tend to go to, apart from India, if you go to the US, if you go to the UK, a lot of the people that Nigerians will encounter when they go are Nigerians. So there's a critical point here around building our systems and ensuring that there is trust within either the private sector or the public sector, such that, this huge funding that is spent abroad can be spent in the country.
It was only recently, gentlemen, here on the square, we had a series on neocolonialism, and that's what both of you have just raised. Let me go back to Dr. Enabulele, and you said something about neocolonialism, the African political leader, to put it rightly, the African political leader. He feels that he still trust his colonial masters, medical experts, so to speak. And both of you have said that the shock for some is when they get there, they found out that some of those to attend to them are Africans. Only very few African countries, Dr. Enabulele, spend 15% of their budgets as agreed in the Abuja Declaration of 2001. And I also recall then you were president of the Nigerian Medical Association. Do you see a problem with leadership here in terms of budgeting concerning the health sector?
Yeah, thank you very much, Suleiman. Clearly, let me emphasize the point that the issue of lack of trust is resulted from the neglect of those facilities by the political leaders. So it still boils down preeminently to the issue of faith leadership, really. And so, but coming down to your question, the reality is that most of what we see in terms of the political leaders, you just captured it. I said it before, the issue of colonial overhang. The issue of what they call secrecy, official secrecy. Oh, they don't want to know they don't want their people to know what is wrong with them and all of that. Now, I give you an instance or two instances. From my own leadership experiences, I had the encounter with some top political office holders. One vowed that he would never allow Nigerian physicians to touch his skin. I don't know whatever led to that, perhaps because they were demanding for their legitimate rights, and of course advancing advocacy for the reform of the healthcare system in that particular state. Now, the governor of that state told me very ridiculously that he will not allow his doctors to attend to him even when he's on his sickbed. And I said, why? He said, no, that he doesn't trust them. I said, why don't you trust them? Because they are demanding for their rights, or they are demanding for the advancement of the healthcare system. Now, there was a second case where another top political office holder said the same thing to me. But unfortunately for that political office holder, there was a session we had one time, a collapse in our presence. And of course, who salvaged the political office holder? It was the same Nigerian physicians that had vowed never to allow to touch him. That anytime he has a problem, he has the next available flight waiting for him to take him to the United Kingdom. But of course, African physicians, Nigerian physicians attended to him, saved him from a life-threatening condition. And today is one of our converts preaching the gospel that African physicians, Nigerian physicians are among the best in the whole world. He's an African leader. He's a top political office holder in Nigeria. So clearly, I see some level of colonial overhang, some level of this impression that, oh, the best must always come from outside their countries. And forgetting that they have a responsibility, they have a commitment to their own people. They are sworn to an oath to develop their healthcare systems, to give them give expression to their health rights, and ensure access to quality healthcare services. So I think it's clearly a lack of understanding of the significant nexus between health system development and productivity, between health system development and even the economic prosperity and wealth of their nations and wealth of their states, because there is that nexus which they fail to understand. So unless and until you have a health conscious, what I call a health conscious political leader who understands the basis of health in driving development, in driving economic prosperity, you will just see most of them attending to it as if it is just a basic electoral tool to be canvassed when they are seeking for votes. And soon after they've gotten the electoral mandate of the people, they go back into their cocoon, to their irresponsible attitude to healthcare development. And of course, the people are left stranded. And so the vicious circle continues where the facilities are left abandoned, loss of confidence, and people aping their political leaders to travel abroad, waste of resources of those countries, and of course, eventual, capital flights, and of course, the marketing of the healthcare space in that environment. So clearly, I still see it as a poor prioritization for health, lack of health consciousness by most of those leaders, colonial overhang, and of course, what I call again, some inordinate quest to line their pockets and of course sometimes launder resources using the avenue of foreign medical trips.
Dr. Agogo, the list is endless. Listening to both of you, from truly, it goes even into the sublime to the very ridiculous. Listening to Osahon give us his experiences with some African political leaders. But again, Dr. Agogo, on an average, Africa can actually save a lot. But let's go back to that PwC report, which has something very, very, worrisome there. I go back to that word, trust. And apart from trust, one of the key things I picked from both of you has to do with the facilities in place. Now, we're not in want of the expert, so to speak, at the moment, but there is a lack, of proper tools to carry out work by doctors. So how has this, been going on? Did that report also try to look at what can be done to bring back this trust? Because as it is now, at the moment, Nigeria's president is away on medical holiday. So it doesn't look any better for the continent, as every African leader still looks outside the continent.
Well, one of the things that we need to be aware of is that this issue of leaders traveling out of their natural countries and going for healthcare, services in other countries is not only in Nigeria. So in Cameroon, there's been that issue. I'm aware in Benin Republic as well. So a lot of the Francophone countries have experienced the same. And I would like us to, my colleague has really spoken a lot about the fact that the political leaders have not done enough in meeting the 15% Abuja declaration, where countries are supposed to invest at least 15% of their budgets in health systems. That clearly hasn't happened. There are other initiatives that obviously haven't happened. The quest towards universal health coverage. Most African countries have not really pushed ahead and are not really meeting those minimum standards. But also as a healthcare professional, and I also need to say that we ourselves, the healthcare providers, need to do a lot more, whether we're nurses, doctors, healthcare assistants, everybody within the health system. We also have a responsibility to build that trust. So government can build that trust on our behalf. So, and then once we are calling for funding, and the funding needs to be fundamental. There's one issue that is happening that, in many countries, in countries like the UK, where you have very balanced healthcare systems, where the NHS provides, care at the point of need, you find in those countries that, whether you like it, whether you're a citizen or not, if you have a need, that need is met. But it's because the government has invested in primary healthcare. So there's a need to look at what is the need. Where is the biggest need? The primary healthcare system is the biggest, but is the weakest healthcare system managed by the weakest tier of government. That's the local government areas, right? And then on the other hand, we have the tertiary hospitals that are managed by the federal government, and these manage or help a very small fragment of our population. So we need to rethink the structure of our funding, the structure of our health system, look at the National Health Act and see how that can be revamped. We also need to look at the healthcare provision, whether it's by the public healthcare facilities or whether it's by private healthcare facilities. There needs to be a culture of quality. We need to introduce quality care and ensure that the patient is the center of what we provide. So you go to a hospital sometimes, the doctor is doing what he wants, the nurse is doing what they want, that the patient is not attended to. So we also, to build trust is not an executive fiat. It's something that both government has a role, the regulators have a role, the Ministry of Health at the state and the national level have a role, the healthcare providers, whether you're a private or a public provider, they have a role. I think that is, some of the key issues that we need to look at. Remember that even in Nigeria, people always trust the mission hospitals. Why? Because sometimes they go there, they know that people care. So that's another critical thing that we need to bring into the conversation.
Yeah, I think you've raised a very interesting point. I want Osahon to also weigh in on this because, there's always a first cause. Something definitely must have ignited that kind of behavior or attitude in some of your colleagues in the medical line, whether nurses, doctors, pharmacists. But again, help us here, Dr. Osahon. I'm sure you have an idea of what Agogo is talking about, that sometimes it's a two-way street here. When we talk about lack of trust, it also has a shared blame on the political leaders as well as the practitioners.
Yeah, thank you very much, Lede. I would not deny that in the healthcare environment, you may find some health personnel who, of course, may not be conforming to the expected professional, relationship. But again, that obtains in every system, and it doesn't now give the impression, shouldn't now give the impression that the generality of the healthcare workers have those same tendencies. What we've seen, for instance, in some endeavors by those in the National Assembly, particularly the House of Representatives, talking about Nigeria now, is a situation whereby you have a one-off engagement with a healthcare worker, maybe in your community, in your village, and the next thing you amplify that as if that is the same disposition by healthcare workers, and you go to the House of Assembly or to the National Assembly to pass laws that have even no meaning to developing the healthcare system, just because of your personal, engagement and propensity. So clearly, I do not deny that you may have some of those tendencies displayed in some of the healthcare spaces, not only in Nigeria, in Africa, even outside the country. But again, you need to ask yourself, what usually gives rise to this? Because these are individuals who live within the system. So the doctors, the nurses, the pharmacists, they're all citizens living within the society. So first, you need to look at internal factors. Are there internal factors that have stretched this health workforce? And that is one reality we need to face in Africa. Today, as I speak to you, Africa has 24% of the disease burden, global disease burden, like you stated in your prefatory remarks. But what is the percentage of the health workforce globally that Africa has? Less than 3%, if at all 3% of the global health workforce. And yet you have 24% of the disease burden. What is the population of Africa? Population of Africa compared to global population is about 16.7, 17%, going by current estimates. And now you have that level, that number of healthcare workers. What do you expect them to do? So they are stretched out. They have few workers waiting to attend to several, patients on the line, long waiting time. Patients now carrying their anger on these healthcare workers. At the point in time, you find out that there is some level of contestations, some level of arguments and all of that, and that impression goes up that, this healthcare worker has no good, has no emotional intelligence or cannot emotionally relate or professionally relate with patients. But I always try to look at the primary cause. And in most cases, you find out that these factors are responsible for, of course, if you like, moderating or, modifying the professional, attitude of most of the healthcare workers. But that is not to say that there is no room for reorientation. There is no room for retraining, which, of course, is always done all over the world, not only in Africa. It is expected that workers get regularly trained, retrained, reorientated to be able to, of course, attend to their professional, have the right professional disposition. But by and large, we have a situation of acute on chronic health worker shortage all across Africa, not only Nigeria. Nigeria, we all know the doctor population ratio, for instance, the health worker population ratio is abysmal. COVID has even come to further undermine the adequacy of the health human resource in Nigeria and other parts of Africa. Europe, the West, they're all taking our healthcare workers because the governments in Africa do not have any proactive, attractive, alluring mechanism to retain their health workforce. So you have now less and less workers, healthcare workers in Africa. And that puts a strain on all of them. So the few people on ground doing more shifts, doing more calls, attending to larger number of patients, particularly during this COVID era. And so that puts a strain on them because they are humans. You need to attend also to their psychological needs, their psychosocial needs. And when it is not attended to, of course, we all know what the Maslow hierarchy of needs talks about. We all know the place of emotions, even in attending to human needs and all of that. So when you fail to also have a systemic approach to all of this, the tendency is to look at them and put blames on them, but you forget the trigger. that, of course, resulted in that. That is not to say that that should be a ready excuse. I am saying, therefore, that we need to balance the issues. Clearly, health workers are doing their bit, even in this COVID pandemic, to see how they can, of course, attend preeminently to patients in need. But again, that is why you have regulations. That is why you have laws everywhere, that people who fall out of line are also taken care of by the extant laws or the regulatory frameworks. Some are rehabilitated and, of course, put back online. And for those who cannot contend with the professional realities, of course, you find other ways for them. But generally, I stand for African workers, health workers. Of course, I'm also the coordinator of the Coalition of African National Medical Associations, made up of national medical associations in Africa. So I know what they go through. I know what the salary of an average doctor is in Africa. Some are paid pittance. In Zimbabwe, for instance, they are paid less than $300 on a monthly basis. Where does that one take them to? So, and that is why you find immigration on a day-to-day basis. The issue of insecurity is there, all right? The issue of poor working conditions are there. So how do you expect a healthcare worker to give his or her best in a rodent-infested environment, in an environment that is not worth even keeping your dogs in? So that is the average, reality we find across Africa. And so that puts a strain again on the African health workers. And that, of course, also modifies their relationship with patients. But again, like I said, it is our responsibility as leaders and as leaders of those healthcare environments to also put in place mechanisms, what we call emotional intelligence mechanisms, to identify those who may not be able to cope, psychosocially, and then pull them out of the system, rehabilitate them, and then get them back to attend to their professional needs. Because you need them, the numbers are low, so you cannot afford to do away with healthcare workers now because they are not there in their numbers. They are not well distributed even. And so the issue of equitable access to healthcare services is undermined by the glut in the healthcare workforce. Thank you.
Quite a lot there to chew and pick on, pick from, especially when you spoke about the trigger. There must be a trigger. The first cause is what we're dealing with at the moment, and it has to do with development, which also, Dr. Agogo, you highlighted in the Abuja declaration, which hasn't actually helped in terms of budgeting for the sector. But it's amazing that in all of this, we have colleagues, your colleagues in government, whether amongst the lawmakers, as well as in the executive arm. How has this helped in, winning the political leaders to your side to helping put in place a better structure for the health sector, Dr. Agogo?
Well, I think we run the risk of moving away from the key topic of the conversation, which is around medical tourism.
Because we're still dealing with the first cause.
We're really focusing
sorry, Dr. Agogo, because we're looking at the causes. Sorry to butt in there, because we're looking at the causes. Because there must be something that pushes everyone out.
Okay. So the truth is that we do have we do have quite a lot of doctors, doctors, nurses. We do have, physiotherapists at the helm of affairs in some of the National Assembly and at the national level. And I think they are doing their best, right? They are doing their best given the circumstances. We are living unprecedented times in the context of COVID, and therefore, a lot has been done in terms of helping to build systems. And ultimately, I think the point that I was trying to make is that for us to really address the issue of medical tourism, we need to build a health system. And so that health system, if you look at the WHO system, health system building blocks, it includes human resources, it includes logistics and supply, it includes things around medication and access to medication, it includes even the enabling environment for health, for medication, for systems to be, for care to be provided, including hospitals and so on. And therefore, we need to, as a whole, look at the systemic approach. And that's what I think, my colleague was talking about, the fact that we need to go beyond, solutions that meet small pieces of the issues and solutions that address, the system as a whole. And we know that we need to work a lot more to build our health system. There are certain global imperatives that we can tap into. One is the idea of universal health coverage. And that's the idea that people should be able to access healthcare at a very basic level. And so it means that in my village, Someone should be able to get basic care. And there are certain things that government has put in place that perhaps we can leverage on. The Basic Healthcare Fund is one of them, making sure that fund is used appropriately. The National Health Insurance, as well as, the community health insurance schemes that the government has put in place are important. They should be funded. They should be managed. We should ensure that people can access those services at the LGA level, at the PHC level. We should look at state government, and you have doctors, nurses running state ministries of health and coming up with innovative ideas and lots of good practices across the country. We need to look at how do they look at initiatives that meet the needs of their communities. We are at the federal level, of course, the policies that should be put in place, the legislation that should be put in place, all those things are part of the health system. And these will contribute to making sure that people can trust our health system and people can also, therefore, use the systems in the country. I mean, we should also think about the private healthcare. Remember that, data shows that up to 60% of Nigerians actually access care in the private sector. And therefore, we need to look at how do we regulate and support the private healthcare providers more effectively to ensure that they meet minimum standards. In countries like the UK and the US, you have systems in place for maintaining health quality, assessing health quality on a periodic basis, healthcare audits, and so we need to look at even the private health providers. How do we make sure that the quality of care that they provide improves? And there's so much, that the private sector can do, government can do a lot, but also as providers, we can do a lot. So I'm not, let's not have the idea that there's one single bullet that can solve this problem. It has to be a review of our system and making sure that it works not only for the rich Nigerians, but also for the poor Nigerians who cannot afford to
I think that's the whole essence while we're having this conversation. We'll take a moment. When we'll come back, I'll bring Dr. Osahon to weigh in on some of those key things you've raised, because those things amount to, making them work. Is not enough to have a small structure somewhere in some of the local governments across the continent and make people believe that that is health being given to the people. And of course, see how we can slow down the exodus of especially African political leaders and Africans moving out of the continent seeking for that one thing that should have been gotten from the continent, which is health care. That's when we return. Join us again. If you just joined us, you're welcome to watching VSA here on News Central Television, looking at one big issue that concerns every African, and that's medical tourism. But again, across the continent, there's a lack of confidence, as highlighted by Dr. Immanuel and Dr. Osahon in the domestic health industry. But again, the absence of cost-effective alternatives to medical tourism. There's very little choices many people have in the face of stubborn ailments and poor local health care. Africa has had its fair share of investments in the medical sector, but this comes at cutthroat prices for the majority of the local population. Crowdfunding has become a common occurrence to save many people from dying. Usually these people are taken abroad because of the lack of confidence in local hospitals and for tourism. In Tanzania, for instance, Indian healthcare investors Apollo have invested in a 500-bed, that is about $70 million hospital that will bring Tanzanians closer to what they seek abroad. Now, however, this comes at a huge cost. Now, there is a partnership that birthed Vision Care, Pasami Eye Hospital in Zambia. Nigeria has also seen the presence of some hospitals owned by foreign investors. Now, the global health industry is a $30 billion market with 7 million people traveling from their countries to medical tourism every year. Good health care is available in Africa, but from all indications, as we've been discussing, it comes at a very heavy cost. We have Dr. Osahon Enabulele and Dr. Immanuel Agogo, both still with me here, and we're coasting home, seeing what form of good we can take out of this conversation to help the continent. Before we went on that break, Dr. Enabulele, I did say I was going to allow you weigh in on some of those key issues raised by Dr. Agogo. He's raised quite a number of issues. He talked about what should be put in place, and he said, well, we don't have a single silver bullet that can help the continent in salvaging the decay in the health sector that has caused a lot of people moving out of the continent. Tell us what you think, listening to him. Are there things that the continent isn't doing in addition to what he's also raised?
Thank you, Suleiman. I have tried to look at Africa without restricting it to any country. And I want to maintain that position because the problem in one African country, is almost the same with what you have in various other African countries. So Nigeria may be used as an example, Ghana may be used as an example, others may be used as an example. So I want to be pan-African in my disposition today because the problems are similar all over Africa. And I therefore want to say that the viewpoints canvassed by Emmanuel are very apt. He has tried to catalog the possible options available for African nations. But I dare say that, to me, the preeminent solution that we should even look at first, as a first step, really, before we look at how to activate the other solutions, is what I call leadership by example by African leaders. You can have all the solutions on the drawing board, and you have African leaders pay lip service to those solutions, and it becomes, a seesaw, a vacillatory movement at the end of the day. So I think the first point we need to appreciate is the need for, the right political commitment by African leaders. They must have the political will. We must have the right political will. We must have the right political commitment, not just in words, but in action, in deeds, so that we all are in the same direction. There is no use having all the solutions that will not be actualized by African leaders. Because like in Africa, including Nigeria, we are not bereft, or we don't have a debt of policies, we don't have a debt of laws. They're out there wasting away in the shelves and cupboards of the political and public office holders. So there's need for recommitment to development of the healthcare system. There is need for recommitment to the fundamental health rights of African citizens. There is need for recommitment to expanding universal health coverage and other opportunities for African citizens. Whether Nigeria, whether Zimbabweans, whether all African citizens need to have that recommitment of the African leaders. So that, to me, is number one. Because when you have that right, then all other things will flow. Because it's the leaders that will generate the necessary momentum to get the other followers to join in the crusade, what you may call a risorgimento of the African health landscape. Now, having done that, we cannot go to the other issues like you raised. And they're very fundamental. Because, again, for you to drive a healthcare system, you must have a situation whereby the systems are on ground. And when we talk about healthcare system, we are not looking at just the public. We're also looking at the private healthcare environment, which, of course, has been largely decapitated in most of the African health environments. Every focus is on public institutions, forgetting that, like Emmanuel said, over 60% from the statistics, at least in Nigeria, first of all, attend private healthcare facilities. And in fact, the beauty of the Indian environment, like people always see, is a private healthcare sector. I've been to India several times, and I'm ashamed to see African political leaders, lining up in some of the queues in India to procure healthcare services. Is shameful. So I think the issue of building healthcare systems is key, and there are several ingredients that we need to touch on, both the public and the private. Now, in terms of the public, we need to be sure that, look, we understand what the system is all about, and that is to ensure that all the levels of the healthcare system are attended to. Because there's been an overemphasis on tertiary healthcare provision in Africa, forgetting that over 70% of the disease burden are basic problems, which you need to attend to at the primary and the secondary healthcare levels. And that brings me to the question of developing a primary healthcare system, like Emmanuel stated. Because even the COVID pandemic has shown clearly that if we had our primary healthcare system intact, we would have been able to handle most of the problems that, especially the issue of home management and all of that, because a lot of them were going to, isolation centers in tertiary health institutions. I mean, clearly the primary healthcare system has been said to be the bulwark, the backbone, the linchpin of healthcare systems all over the world, whether in Germany, whether in the United States, whether anywhere. So we need to be able to build healthcare systems and have a proper referral system. And that will help us to also checkmate this untold, outward medical tourism. Because if somebody knows that, look, there are levels of care and the facilities are well known to be of standard, to be of quality, then none of these things will happen. Now, we need to have appropriate leaderships in terms of governance at all those levels of healthcare administration. And that brings me to the question you raised in terms of who are those managing the healthcare system. I mean, it's not enough to be at those leadership levels. The system generally needs to work to be able to even motivate those at those levels. Because sometimes you may even be a commissioner, and you may be a commissioner in name, and yet you have a boss who does not even allow you access to his space. So there must be some committed leadership, responsibility with, of course, with the necessary autonomy. I mean, guaranteed for them to give expression to the issues that are involved in the healthcare administration. Because there's no use having a leader in the healthcare environment who has no access to even the superior boss, in this case, the political leaders. So they need to be empowered. They need to have autonomy matched with responsibility to be able to, of course, give account for what they are doing to drive the healthcare system. So we need to have a pure and simple referral system that people appreciate, that moves them from one level of care to the next, so that you do not overburden the tertiary healthcare system just now, and those ones are now able to attend to the very serious issues, specialist issues that they are supposed to attend to. I also think that because we are talking about medical tourism, there is need for most of Africa, for most countries in Africa that do not yet have a national health act or a legal framework to have that in place. We tried to do that in Nigeria when we were fighting for the National Health Act. And I'm happy that we put a provision there, Section 46 of the National Health Act, which really, if expressed, ought to be to be able to restrict untold outward medical tourism by political office holders. But of course, when the president is already breaching it, what do you expect in terms of the implementation of such provisions of the National Health Act? In Section 46 clearly negates this kind of reckless behavior that we are seeing from most political office holders. So in Africa, if that is put on ground, to put some defined expressions, limiting this nuisance that has led to the very huge loss of resources from Africa, that also will help. Of course,
let me quickly bring in Emmanuel here. So, sorry to cut you there. Because we're winding down. Dr. Emmanuel Agogo, you've had Dr. Osahon, stretching it, going beyond where you left off, but again, you agree that there are investment opportunities in Africa's health sector. That is one area you've been practicing. But how encouraging is it for as many that may want to venture into that business of investing in health sector?
I think, I've spoken at a few investment fora talking about, the health business in Africa generally, not just in Nigeria. And just to take you a little bit step back, before the COVID struck the African continent, there was something called the Joint External Evaluation of the International Health Regulations that was conducted in virtually all 99% of the African countries. And I was involved in a few countries, Ghana, Gambia, Seychelles, and Nigeria. And one of the things that did was to evaluate the healthcare systems in those countries, especially regarding healthcare security. But a component of that was, logistics, supply chain, human resources for health, as well as, the ability for countries to address medical countermeasures. So one of the things that came quite clearly across the whole African subcontinent was that, no country was really ready apart from South Africa. And even then, in the reality of responding to COVID, we saw the gaps that were clearly seen. The fact that in many countries, there was no oxygen. In many countries, they did not have any specialists with expertise in intensive care medicine. There were no in many countries across Africa, they did not have, nurses who could manage an ICU. So we're saying, oh, where are the ICUs? Where are the oxygen? Where is this? Where is that? So it's really beginning to think beyond, this kind of approach where we are, addressing things based on emergencies. There are significant investments that come into many countries in Africa, but very focused on specific disease areas. So beyond the funding that countries in Africa get from their various internal IGRs, the Global Fund invests in HIV, TB, and malaria. The World WHO invests in non-communicable diseases. The US CDC, the Public Health England, so many funders invest in specific disease areas. And one of the things that needs to happen is that there needs to be more of a concerted approach to aligning these investments. These are investments that are coming from donors. But from the business point of view, Africa has the youngest population in the world. And that is one of the reasons that, people are thinking may be responsible for the way COVID, played out in Africa. But that means that as we are the biggest, youngest population, we are also the population or people who are going to be aging remarkably in the next 20 to 30 years. And so we will, with the lifestyle we adopted, the need for healthcare is not going to become less. The need for women to have babies, the need for people who will have, unfortunately with their lifestyle, diabetes or hypertension, unfortunately, the people who will have cancers, those needs will be there. So there's a huge potential investment that is there, especially where we can provide good quality care. There should be no reason why everybody should go, every diagnosis should be malaria or typhoid. There should be tests that can be done to really tell you this is what the problem is. That the investment potential that's there in training healthcare workers. A country like Philippines exports our healthcare workers. Why can't we do that? There's a potential in providing healthcare either at the primary healthcare level, the secondary healthcare, or really specialized services like renal transplant, heart transplants, and so on. There's opportunities in radiology, in diagnostics. The opportunities, even in the area of medical education. So I think that, there's so much that can be done, and we need to attract those investments, and both beyond our leaders, those who have the resources should invest in these services, and our government too should meet their Abuja declaration that was done in Abuja, where the discussion of, thank you.
Well, I experienced a glitch there, Dr. Immanuel Agogo. I think the connection, the internet connection to you, there was a glitch there. But anyway, let's close with Dr. Osahon Enabulele quickly here, if we can do this in a minute. Dr. Osahon, I also recall there were times on the continent, specifically, let's bring this about Nigeria. Once upon a time, the Saudi royal family came to the University College Hospital, Ibadan, seeking medical, attention. Do you think the continent has what it takes to reverse that trend that will see people come from all over other parts of the continent to Africa, seeking experts like yourselves?
It is left for our governments to take the needed courage to show the commitment to galvanize the people towards turning around this whole specter of outward medical tourism. I wrote an article that was published in the World Medical Journal in August last year, and it was titled COVID-19 Pandemic, a possible reversal mechanism for outward medical tourism by African political leaders. I was very hopeful that because COVID had indubitably, reconditioned the psyche and the attitude of our leaders, that perhaps it may also be possible to have a sustenance of that disposition. But I say with all sense of responsibility that I was very disappointed when Mr. President of Nigeria, just soon after the gates were left open, is back again to United Kingdom. So that does not inspire anybody. But again, the people need to demand for a return of the needed investments, the needed commitment to the healthcare landscape, both by the leaders and those who want to invest. But again, a lot will depend on the political leadership. I hope and I pray that as we were locked up in our countries, as we were beginning to see the value in local production, as we begin to see an expression and liberation of our indigenous energies and potentials, that perhaps people will galvanize that and see how in the post-COVID-19 era, we can have a sustained development of the healthcare infrastructure, the health human resource base of our country, commit ourselves to research endeavors, commit ourselves to quality healthcare dispensations, and hopefully with all other social determinants being taken care of, that people will begin to see Africa as a destination for medical tourism. So enough of the demarketing of the African healthcare environment by the frequent foreign medical trips by African political leaders. Let the people demand account from their leaders. And together, I'm sure we can rebuild the African health landscape to cater for the needs of African citizens and even foreign citizens. That's the way I want to see it. Thank you very much, Aledi.
And for you, Emmanuel, let me take that word from Osahon, demarketing. How promising can public-private partnerships be in the health sector help demarket that sector?
Well, I think that there are a lot of examples of public-private partnerships that have already started being successful. There are some in Abuja with Garki Hospital and Nisa Premier. There are some in, with in Nasarawa, for instance, and as well as in Benue, where I know that, private sector are providing like diagnostic services for organizations like, the human health, hospital assist and so on. So the thing is that there are already models that we can look at that where the public sector, where the private sector can work much more closely with the public sector. And I think also that we need to leverage telemedicine, which allows, local healthcare providers, whether they're private or public healthcare providers, to link in with doctors in the diaspora. Nigerian doctors like myself who were there for many years, who are willing to provide services. We can leverage technology to provide care that improves trust. Private healthcare providers can also link in with other, the so-called big hospitals globally and provide this care, so we can use technology to bring healthcare locally, so to the common man in Nigeria. So while we are not happy that the president and a lot of political leaders are leaving the country, we should not forget the millions of Nigerians who still need healthcare. And we need to push forward to make sure that they also can access that good quality healthcare wherever they are, whichever state they are in Nigeria, and they can get, like Osahon said, care at the primary healthcare level where they can be appropriately referred, upwards to the secondary or tertiary healthcare when they need it. And so the final thought really is that we need to make sure that health insurance, health access is prioritized, not only for the rich who can afford to travel, but even for the poor who cannot, because catastrophic health expenses are still a reality in Nigeria. Many people have their savings completely eradicated by having one illness in the family, one severe illness. So we need to think beyond just the angst of the leaders who are going out of the country and think about building a system that can take care of the 200 million Nigerians, which is both an investment opportunity, but also a human care, a health right for our individual citizens, for the individual citizens of the country. Thank you.
Well, it's a fine place for us to leave it. Always a delight having both of you join us on the show, speaking on how best to help the continent. Because as it is now, African leaders are on wings, flying high, crossing many seas and oceans to solve the simplest medical challenges. Back home, the healthcare sector is crippled and struggling to rise from its ruins. Medical tourism to the rest of the world, but the tours are not reciprocated. Well, it's the situation of Africa at the moment. Many thanks for being such nice company, Doctors Osahon Enabulele and Emmanuel Agogo. I hope that again we'll have you on the square. And to all my viewer, I'll see you tomorrow. Bye-bye.